Hello everyone, kia ora. Welcome to this Goodfellow webinar. Today we're talking about sex, addressing sexual difficulties with your patients. My name is Grace, I'm a GP and I also work with the Goodfellow Unit. Tonight I have with me Allyson Waite. She is a clinical psychologist and she's also a regional director at Sex Therapy New Zealand. Over to you, Allyson.
Well, hi everybody, and thank you very much for the opportunity to be here. As the title says, I'm here talking about sex and thinking about how to address sexual difficulties in a primary care setting. So my background, as Grace said, is as a clinical psychologist, so I'm not medically trained, and I can see a few questions popping in already. So unfortunately, I'm not able to answer questions specifically about things like medication, but I guess what I am here really to talk about is the importance of putting sex on the agenda, and so it's really great that it's here on your agenda today. So I hope to cover these kind of main topics really. Firstly, thinking about why talk about sex. It's an area that I think, is about all of us. And the World Health Organization talks about sexuality as being one of the central aspects of being human. So it's important and it's relevant to everybody. And obviously in primary care, practitioners are often a first port of call for people. And so it may well be seen by people as the most appropriate place for them to raise issues around sex and sexuality. So I'll be talking a little bit about how to have the conversation, how to create opportunities to bring that up with patients or clients. And then I want to talk a little bit about kind of protocols or models that you might use to help you do that. And really much of the protocols are really underpinned by a formulation and a conceptualization of sexual difficulties as being biopsychosocial. So I want to be thinking a little bit about what that means and how that can be used to kind of guide our assessment, what information we need to gather so we can plan treatment and intervene and evaluate the outcome. And then I wanted to finish off just by talking a little bit about some referral sources and also some resources online that might be helpful for you or your patients. So why talk about sex? Well, sex is important. The World Health Organization says sexual health is a state of physical, emotional, mental and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction or infirmity. And it's really also important that we think about things like pleasure and satisfaction and enjoyment and intimacy. These are all experiences really that people may struggle with, whether or not they experience a sexual dysfunction per se. And of course we need to think about things like safety and consent, and that sexual relating isn't coerced in any way. And what we know now from growing research in the field of intimacy is that there are significant correlations between sex, our emotional health, our psychological health, and even our physical health. The Global Attitude of Sexual Attitudes and Behaviours survey found that 80% of men and 60% of women rated sexual function as moderately to extremely important. And there's a high prevalence of sexual difficulties. Of course, it's really hard to study sex, but it depends who you ask and what you ask. But generally, these findings are that up to 31% of men and up to 43% of women will experience some kind of sexual difficulty. And these are usually associated with poor physical and emotional health outcomes and negative experiences of sex. So it's something that can affect many, many people, and that's why I think it's really important that we be on the lookout, I guess, thinking about comorbidity of things like health difficulties, chronic illnesses, medications, that it's highly likely that they will be influencing or have the potential to impact on sexual functioning. Also, we need to be the ones to ask. Patients see primary care practitioners as the first contact, but frequently struggle to bring up the conversation themselves. And what we also know is that us as providers may struggle to bring up the conversation. Less than 10% of sexual issues are generally discussed with a healthcare provider. And if we think about the statistics of the prevalence rates, then I guess there's a lot that isn't being said or being asked about. So I really want us to think, today about eliminating the barriers that exist between us and our patients or our clients so that we can create a cohesive and patient-centered dialogue that allows us to appropriately assess and treat any sexual difficulties. So the phrase opening a can of worms, if we think about what are some of those barriers to managing sexual dysfunction in primary care, well, there's barriers within us as health professionals, and that might be things like lack of time. I have the privilege of working with people for an hour at a time, but 10 or 15 minutes with people who may have a list of difficulties. So it's often about prioritizing what you can in that time. It's also about our own comfort or confidence or knowledge. We might be worried about opening a floodgate and, well, how do we get all the can of worms back in the box before someone leaves? We're also maybe conscious about differences between us and our clients in terms of gender, sexual orientation or culture. And what we also know is that our clients and patients will be experiencing this as well. They might feel shame, embarrassment, fear of disapproval or judgment. They may not know how to put words to their difficulty, or they may perceive that the differences between themselves and you as a health professional are in some way a barrier. So those are frequently, I guess, things that might stop us with all the best intent from actually being able to have the conversation. So how to help? Well, the European Academy of Sexual Medicine really argues for three principles that underlie sexual medicine. One is the adoption of a patient-centered framework, so that's working together and collaboratively in a client-based way. Application of evidence-based medicine, and I guess that tends to be a small literature, but a growing literature. I think there's much more, in the same way as there has been with things like mental health and depression, there is much more a move in the recent few years to kind of look at combined treatment. So what is the evidence base for both medical interventions and psychological interventions to treat sexual difficulties? And also having a unified management approach to treatment. So sexual difficulties are often complex, they're multifactorial, so we need to be thinking in really broad ways about what we need to do to help. And I've also added a note in here about respect for diversity. And I guess by diversity, meaning that there are so many ways in which we may identify our gender, our sexuality, our sexual orientation or gender orientation. So thinking about fluidity, who we have sex with, who we're attracted to, what we like to do, what we don't like to do. There's an enormous variation, and I think it's really important that we kind of are aware of our own perhaps assumptions or boundaries or what might come up for us, but recognizing that within those limits of what's safe or consensual or not harmful, then there really is a range and diversity of sexual experience. And so we may need to kind of stay open to hearing about that, especially if that maybe is different from our own experience. There's also diversity of presentation. So sexual dysfunctions are, of course, essentially self-reported and are on a continuum, right from sexual concerns or difficulties through to formally meeting kind of DSM criteria for a sexual dysfunction. And people may or may not present with biological findings. So it may be that someone doesn't have a biological cause for their difficulties, or in fact doesn't report any sexual dysfunction per se, so they're still able to experience desire, arousal, orgasm, but they may not experience sex as fulfilling or satisfying in some way, even in the presence of sexual functioning. So we need to think about that as being a reduction or absence of satisfaction with any aspect of sexual experience and not just sexual functioning. There also may or may not be subjective report of distress. There's likely to be an impact on the person's kind of sense of self, their psychological and emotional well-being, but it may also be that the main impact is on the relationship with their partner, and so the distress is in the context of relationship. If somebody is in a relationship, then sexual difficulties will of course impact on both partners. So the framework allow, I think, is a useful way of us thinking about this, and there's kind of the first part is all really. So the first thing is asking, so creating an opportunity and starting the conversation. And then legitimizing, which I think is about kind of validating someone's concerns or fears, being able to kind of acknowledge the importance of the difficulties that they bring to you. And sometimes appropriate to kind of normalize. You know, there are so many myths and misunderstanding, people's understanding of their own bodies, of kind of messaging that we hear, you know. So sometimes there's a lot of things that can be just really helpful to kind of normalize and legitimize why someone might feel the concerns that they do. And then I guess also recognizing our limitations, whether that's because of our own confidence or knowledge and competence and skills, or kind of reaching a point of feeling actually this is beyond that might be all that we do, but really seeing, I guess, that those three things are in themselves an intervention. If you've created a space and an opportunity to allow people to explore the difficulties sufficiently, that you then may refer on if you feel that that's you know, the A, the L and the L. And if not, then kind of opening up a dialogue and planning treatment together by having more in-depth conversations or being able to explore issues in more detail and working together to develop a kind of treatment plan, whether that's with yourselves and with the inclusion of referrals onto other specialists, be they medical or psychological. So how to open the conversation? I guess there's no one way. There are so many opportunities. When we think about sex, sexual functioning, sexuality, it really is a biopsychosocial construct, and so there may be any opportunities when someone's here presenting with a medication side effects or a chronic health condition, maybe the opening way to actually create an opportunity to ask about sex. We're often really comfortable about asking side effects of other side effects of medications, but we know that so many medications, particularly things like SSRIs, will have sexual side effects, and many people don't know that and feel too kind of afraid to ask. So things like medication can be a really helpful way in. And I think providing a context and permission to inquire. So, of course, these may be really sensitive areas and a really intimate part of somebody's life. So I guess just getting permission to ask a few questions, you know, things like, would it be okay if I just asked a few questions around this? I notice, you know, that that's something you've brought up, and would it be all right if we explore that a little bit more? I think it's really important to try and stay open and broad questions. You know, if the difference between asking someone what's happening sexually, if nothing's happening, that may already kind of close down the opportunity for the conversation because of shame or embarrassment. So what's happening or not happening, you know, somehow kind of gives that permission that, you know, both of those things are possible and both of those things are okay. So we need to kind of have a flexible, of course, empathic, non-judgmental approach to asking these questions. But I think being direct is also really important because of shame or embarrassment or lack of language, people might talk kind of around, they might use euphemisms, and so it's really difficult sometimes to kind of know the specifics. And I think we particularly need to start to ask, you know, if somebody is coming in and talking about difficulties with orgasm, but actually they're not able to get an erection. So it may be that they are kind of using the way that they feel it makes sense to them to describe the question, but we might need to ask some specifics in order to get those kind of details. And I'll cover that again in a few slides. I guess thinking again of just about the language that we use, you know, clients will come in with their own language, and I think it's judging, you know, what feels appropriate or feels comfortable to use. But I guess really being able to model that, you know, it's everyday language, it's okay to talk about these things. And as I said earlier, just being aware of our own biases and assumptions, and not that it's not okay to have them, because we're all human and we will all have those experiences and those boundaries, and it's just being aware, I guess. The more we can be aware of what our own limits and boundaries are, the more able we are to kind of help and be available to a client or know when to refer on if it's outside of those boundaries. So here's some general broad questions. Like I said, tell me what's happening or not happening. Are you presently active sexually? Are you satisfied? What could improve things? Are there ways that you're not satisfied? Are there any sexual difficulties or problems you'd like to discuss with me today? So these are the kind of the opening questions. And again, using kind of those contexts, you know, so normalizing, generalizing. You know, we know that people who've had taking this particular medication can experience difficulties. It's normal. 40% of people who use this medication will experience these difficulties. Somehow that kind of creates that permission that it's okay. You know, this isn't just me, because people can feel an enormous sense of isolation that could be adding to the difficulties that they're experiencing. So these are just some ideas, and probably they're all things that you would be kind of using in other contexts and thinking here, you know, how do you apply that when talking about sex? So this is the International Consultancy for Sexual Medicine algorithm, and again, it's really a sort of stepwise approach that's based primarily on a biopsychosocial model. And the first step is that basic evaluation. And so depending on the context or your role, you're needing kind of, if you're in a medical context, then you might do much more detailed medical assessment, referral for lab tests, physical examination. But the importance even within that of doing a brief psychosexual and sexual history. Or if you're working as more of a psychological, a therapeutic arm, then of course your emphasis is going to be more on the psychological aspects and the more detailed assessment. But I will always, with clients, check out whether they've been to see their GP, or recommend that they go and see their GP just to have kind of physical screen or look at any medical or organic things that might be going on. It's really important that we think about this in a really multidisciplinary way. It could be far too easy to go down one track and actually have missed a whole piece of the puzzle, which would quite change the picture of what we need to do. Then step 2, I guess, is about interpreting those findings. So the etiology of the difficulties. Is this something that's primarily biological or organic in origin? Is this something that's more psychological? Or in fact, is this something that's both? And I guess what we really know that is, even if there's a difficulty has a very strong or primary biological, then it will have psychological aspects that both contribute to the difficulties. So anxiety, someone has erectile difficulties and repeated experiences of feeling that they've kind of failed in some way, will start to often set up anticipatory anxiety, and anxiety of course will interfere with relaxation and sexual functioning, might lead to relationship distress, and so very quickly can kind of lead to psychological and relational consequences, even if they hadn't sort of been the original kind of cause. So it's kind of really helpful to be thinking less about, you know, is it either or, but potentially both and. Then step 3 is thinking about the patient and partner education and decision making. So what would be the most helpful way forward for this person at this time, and together developing a shared treatment plan. And I guess they also really emphasize the importance of follow-up, both in terms of things like medication review and adjusting dosages, but also in a psychological way, then actually as you kind of go through a therapeutic process, you know, what other things might be coming up, or how you might need to change the intervention, so that we're kind of constantly evaluating the outcome that we have set in step 4. So assessment's aiming, of course, to really identify the underlying etiology and the consequences of the problem. And I think I've probably said much of this, but you know, regardless of etiology, sexual dysfunctions have psychological, behavioural, relational, and physiological consequences over time. So here's our biopsychosocial model with sex in the middle. And I just wanted to spend a little bit of time kind of going through each, because again, I think these can be pointers for questions, to base questions around, or almost screening questions. So there's high correlations of sexual difficulties with medical conditions, chronic illnesses, medications, surgery, hormones, pain, fatigue, and aging. And I think, you know, we often have kind of models of our own experience of sex that fits perhaps when we're younger or when we're healthy. Very often they've been informed by the kind of cultural messages, what we see in the media. Very often they can be very much a kind of performance-based model of sex. And that may well work, often not even when you're younger, but certainly as we age and our bodies age, then we need ways to kind of adapt to our changing bodies, both physically, but our changing life stage, changing circumstances and relationships. And so being able to constantly kind of evolve and redefine and re-experience sex across our lifespan is really important. And I think very often sex and aging doesn't get kind of spoken about, and so people may really struggle or feel like they're experiencing sexual difficulties when in fact they're experiencing kind of normal age-related changes. And so just having, again, some basic facts or understanding about what happens to our bodies as they age can be really helpful, like, you know, the changes that would happen with erectile functioning even in healthy older men. And of course, sex is neuropsychophysiological, so our brain, the biggest organ, can be accelerate or break, which really brings us onto the kind of psychological factors. And this is by no means an exhaustive list, but, you know, we can really think about anything has the potential to impact psychologically. So that might be, you know, actual experiences from the past, good, bad, or indifferent, or traumatic experiences. The cognitive factors are attitudes and beliefs and expectations, and they will be shaped by our early learning, the messages that we grew up, the models of sex and intimacy that we saw around us in our families or in our friends or in the media. Things like self-esteem and body image hugely impact on sexuality. Things like mental health, depression and anxiety, and then more broader things, people's life events, stresses that might be going on. So kind of when we start to think about all of the factors, in a way, it feels like, yeah, sex is really complicated, and these ideas that sex just kind of happens, actually we're having to incorporate or accommodate quite a lot to be in a space where we feel relaxed, we feel open, we feel willing to engage sexually, where we feel a sense of kind of positive anticipation and expectations for sex, that we feel a kind of permission without shame or guilt getting in the way. And of course, performance anxiety, you know, I mentioned earlier, you know, that idea that, you know, sex needs to be a certain way, and if I'm not measuring up, people being very much in their heads and observing themselves and monitoring their performance and not being in their bodies and moving away from the sense of kind of intimate connection or sensual pleasure. So
just a question coming in. Someone's just asking, what age should we normalise sexual difficulties in men?
That's a good question, because I think the normalizing is that actually erectile difficulties or erections change, you know, from kind of the age of 50s, there are changes in hormonal levels, and erections may be kind of more waxing and waning, or maybe needing more stimulation to get an erection. So these are things that might change compared to younger men. I guess where we draw that line of, you know, defining it as a sexual dysfunction versus normal aging change. And if you think about the DSM kind of criteria, then it would need to meet those criteria as to sort of whether this something is a dysfunction. But even in normal age-related changes, then these psychological factors that we're talking about can compound and really cause sexual difficulties, even when it's normal age-related change, if that makes sense. So if we can help people to accept those changes, to accommodate, to adjust to those changes, not to be kind of anxious or self-critical if they lose their erection with a partner on one occasion, or find it more difficult under stressful experiences. You know, that may be part of a normal variation of sexual functioning, but it could be very easy to set up the idea that this is something pathological or problematic, and actually anxiety then really starts to kick in and set off that cycle. I don't know if that answers the question, but I guess in terms of age changes, then, you know, really from sort of late 40s, early 50s onwards. And I've got a slide later that talks about the incidence of erectile difficulties with age.
Thank you.
Okay. Then I've sort of mentioned this, you know, the whole kind of broader, what messages have we internalized that will shape our own sense of ourself and relationships and expectation, permission for sex, what is acceptable and not, and they will come from a variety of sources, from family of origin, maybe religious, cultural, social, political even messages, and certainly the media plays a huge part. And even I think, advertising, for example, and if we think about the advertising for Viagra, and there's a leaflet I've got for Prilogy where there's a couple doing some kind of yoga together, like this really advanced gymnastics. So it really kind of perpetuates this myth that actually we need an erection and we need to have an orgasm in order to enjoy sexual and intimate relating. So I think we've got to be careful how, in a way, that can perpetuate some unhealthy narratives. And if we can help people to kind of broaden that idea that, if I've experienced post-surgery prostate cancer and had nerve damage, and erection may never be something that is possible again, does that mean the end of my sexual life or relationship with my partner? Can I find ways to continue to enjoy sexual relating and intimate relating? And so very often these internalized messages are part of what we need to kind of challenge and broaden.
Sorry, just before we move on, you had a little note there about sexual identity. Someone's just typed in a question about uncertainty of sexual identity with oneself, but presenting as sexual dysfunction. How would you manage that?
Well, I think that would be part of the assessment, is that actually, is this sexual kind of dysfunction, or is this more about some struggle for that person in terms of beginning to kind of understand their sexuality and their sexual orientation. And I think, what's really important is thinking about the difference between sexual attraction, sexual behavior, sexual orientation. They're actually all kind of independent things. And I think so from a sex therapist point of view, it would be kind of exploring the meaning and the challenges and how that is impacting or contributing to the sexual dysfunction. So I guess, just on that little bit of information, it may be much more around the psychological aspects of helping this person to become aware of and comfortable with their sexuality, whatever that is. And I think we, really try and move away from these kind of very binary definitions of gender or sexual identity. So, yeah. So these are just some of the myths that I think, I'm referring to, this idea that sex just happens. It should happen spontaneously. It's always easy. It's always fabulous. You have to be young and fit and healthy. You should always feel lust. Sex is intercourse and orgasm. Men always want sex and women don't, and everyone else is usually doing it more. But these are things that I hear, all the time, and people feel therefore that they're not measuring up in some way. So these myths are really, I think, quite powerful. The psychoeducation that these are myths and aren't actually factual reality can take an enormous amount of pressure off people. So they're there really as a prompt to kind of think, some of these narratives that we're hearing can actually certainly cause or maintain sexual difficulties. And of course, sex isn't always, or nor should it be always, in the context of relationship, but sexual difficulties often impact on the dance of intimacy. They might be the cause of underlying difficulties. So sexual difficulties may create emotional intimacy difficulties, or other difficulties, emotional intimacy, other issues in a relationship may manifest as sexual symptoms. And often sex is around the communications of needs and desires, the balance, the reciprocity and sharing. So any of these things, these dynamics that might be happening in relationships, might be part of what needs to be explored. And there's often comorbidity, so I think that's really important too, that sometimes sexual difficulties in a partner may be related to sexual difficulties in the other partner. So it's not uncommon sometimes for a male partner with a female partner who experiences pain or loss of desire that they might experience erectile difficulties or early ejaculation in a way as a response to the difficulties. So it's often really important to ask about if someone is in a relationship, what might be happening for their partner, and certainly the impact of the difficulties on their partner. So I just wanted to talk a little bit about erectile difficulties as a bit of an example of that biopsychosocial. So here are the kind of stats that obviously with age, the incidence of erectile difficulty goes up. And erectile difficulties have been called a cardiovascular disease, and in fact a predictor of cardiovascular disease. So I, for example, would always ask men to go and make sure that they've seen their GP, because sometimes erectile difficulties could be a symptom of an undiagnosed cardiovascular problem, particularly if someone has, high blood pressure or high cholesterol, diabetes, obesity. These are all things which, are seriously going to impact on vascular health and therefore on erectile functioning. So if we think about erectile difficulties, there's very often, particularly in older men, and obviously these health conditions are more prevalent with age, then there's fairly often a biological component. But there's also a psychological component, like we talked about, of self-esteem and anxiety in relationship to stress. So I wanted to kind of give an example of that. This is these cases are published cases. They're not mine, obviously, for reasons of confidentiality, but I think they describe the often common kind of presentations. So a man in his 50s with a 6-year history of erectile difficulties that have been happening kind of intermittently but getting worse. So a man with mild hypertension, a smoker, on low-dose medication, and testosterone levels and other lab results kind of, nothing significant. So there was some kind of physical or biological aspects and age that were contributing, but also presenting with really reduced desire. So it's very common sometimes that changes in desire may be secondary to another sexual difficulties. Obviously, if I feel that I'm not going to be able to get an erection, or I feel worried about that, then that might have the potential to impact on my interest in sex. So that was kind of, for Luke, that was something that he was presenting with. And again, very often when sex becomes less frequent, then other forms of intimacy become less frequent. So non-sexual touch, affection can often reduce in relationships too, because it becomes very blurred about, if I reach out and give you a hug, is that going to be interpreted as an initiation for sex, or is that going to be expected? And so I think that's a really common pattern that, it starts to have much broader relational consequences in reducing desire and affection, leading to a loss of confidence and avoidance of sex and intimacy. And so for Luke, that started to lead to relationship stress, which became another factor in maintaining the difficulties. There was conflict that developed around that, and also kind of grief and loss related to some bereavements in the family, which again, I guess we can think of as a contextual factor. So a really typical presentation where you may have a whole lot of those biopsychosocial factors at play all at once. So in terms of assessment, I guess the medical we've covered, and sexual functioning, it's really important to get some more detail about that, and I'll come on to talk about that in a minute, and sexual history and psychosexual factors. So some useful clarifying questions, I think, is to get a description of the problem, when, how often, who with, and how long has the problem been going on. One of the most useful things of sort of DSM frameworks is really the idea of this is this lifelong or acquired, and they may be very different causal reasons. For somebody who's had a lifelong difficulty, say something like early ejaculation, there's some suggestion now that perhaps men with lifelong early ejaculation may have some predisposition or genetic kind of predisposition and sensitivity, and that may require a very different intervention than a man who's developed early ejaculation in the context of stress or some other circumstances later in life. Also, whether this is generalized or situational, I think those questions really help us to kind of tease apart the causal reasons. If this is something that is always happening with my partner in every situation, is this something that's happening only sometimes with my partner, and if so, what are the contextual things that make a difference there? Or is this as commonly happens, only happens with my partner, and actually sexual functioning by myself is okay, and masturbation, so things like the relational dynamics and performance anxiety are obviously far less present, by yourself than they are in the context of a relationship. So those kind of questions of the duration and the circumstances are really important. I mentioned earlier partner's response, what might be how the partner responds to the sexual difficulties, but also any of their sexual difficulties, and also what the kind of the goals and the aims are for a person. Some people may want a quick fix. There may be a whole lot of things that are flagging up as potential causes, but people may not want to kind of go down that route. I'm thinking generally in psychological treatments, if someone wants symptom management, then actually that's an appropriate place to start, rather than necessarily delving into the underlying causes, if that's sufficient to resolve the difficulties. And so the sexual response cycle, I'll come on to talk about in a minute, but these are some screening tools that I believe are widely available, and the International Society for Sexual Medicine publishes a whole lot of sort of standard operating protocols and guidelines, and so these should be available online. As the brief symptom checklist is kind of like a 4-question checklist, and I think the other one is about a 10-question checklist, just asking about how frequently difficulties happen, so they can be useful screening tools. So here we've got the kind of human sexual response cycle, this sort of slightly maybe questioned now, as being quite gender biased, but this triphasic that we have kind of desire, arousal and orgasm, and the DSM diagnoses are kind of based along here. So this is also kind of a framework to be thinking, am I just checking out sexual function if someone's coming and presenting with arousal difficulties, but I do also need to ask about orgasm and desire, because actually the difficulties may be arising somewhere else in that sexual response cycle. And what's not on here, which I think is probably the most important, is the stage before desire, which is willingness. So if I'm not willing to be open or not wanting to be sexual, then actually I'm very unlikely to experience desire or arousal. And willingness may be impacted on by any of those biopsychosocial reasons, but actually that would be the place that you may need to start. If somebody's not wanting to be sexual for a reason, then kind of working on techniques to improve orgasm, it's really kind of starting in the wrong place. And these are the kind of categories under the DSM-5, which was kind of revised a few years ago. So the desire disorders for women have now been combined into this interest and arousal disorder. And I think that's because of the idea that, rather than that linear sexual response cycle, the idea that, for women it may be much more of a circular response, and that desire and arousal are far harder to kind of differentiate and kind of may coexist in terms of sexual response, rather than being a linear process. And also the changes around sexual pain disorders as well, so dyspareunia and vaginismus now being replaced by this diagnosis, genito-pelvic pain disorder. So then steps 2 and 3. So how do we conceptualize the problem? Is it organic, psychogenic, or both? And thinking about what our aims of treatment are is the restoration of lasting and satisfying sexual function, which might require a multi-dimensional understanding of the forces that created this dysfunction. And so we may be trying to resolve the symptoms, but that may be we're also just trying to improve satisfaction or enjoyment or reduced shame or distress, even if the sexual symptoms kind of remain. So we need a really kind of broad treatment goal, I guess, or aim of our treatment. Another acronym which are always really useful, people might be familiar with this one, but we've talked about the permission, and I think the next intervention is giving limited information, which we've talked about might be psychoeducation about sexual functioning, how our bodies work, lifestyle factors, lifestyle modification, debunking myths, helping people to find some really useful literature to read. We might be making specific suggestions and recommendations of lifestyle change or prescribing medication, and then perhaps referral on for a more intensive either psychological and or sex therapy. So thinking about those as kind of staged treatment goals. And what is the first line treatment? You know, as I said just now, thinking about partly it depends on your conceptualization of the etiology, but also the patient's goals, motivation, and choices. So I think it's about presenting kind of all of the options, and it may be any combination of those options as a first line treatment. And then I think I've said this, the treatment outcome is focused not just on the resolution of symptoms, but reduction of distress and overall improvement and follow-up. So psychosocial treatments might really be kind of focusing on things like predisposing factors, so maybe resolving past trauma or early messaging about sex. That might be something which, you know, has led to or caused a sexual dysfunction later in life. And so it may be that the treatment really requires to kind of go back and resolve some of those early difficulties. It might be that you're addressing the precipitating factors and the contextual things, or maintaining factors, things like anxiety, difficulties of communication in relationships, lack of information or awareness of our bodies. So we're thinking about, in a psychological or sex therapy approach, that we might be addressing any of these elements, or all of these elements often. So the general role of sex therapy, I would say, is kind of these things. I think, you know, certainly one of the things that I really drew me to this is the individual nature of this work, that, you know, sexuality is very unique to that person or that couple at that time in their life. And so, you know, that the kind of individual treatment will look very different for different people. But I think in a way these are some of the broader principles or aims that we're trying to achieve in sex therapy. Very often it's about providing emotional support and validation of difficulties, psychoeducation, things that we've talked about in terms of function and lifestyle factors. It may be helping people to kind of learn about how their bodies work. So many people haven't been told or haven't been taught, and it was never talked about, and may have had a kind of hour biology lesson at school, but hasn't really prepared the skills necessary for intimate relating with another in adult life. So we might be helping to kind of redefine narratives around sexuality, really to kind of reduce performance anxiety, reduce distress, and encourage self-acceptance. I think, you know, very often people highly self-critical, judgmental, and, you know, very often that's not conducive to a sense of relaxation and permission if you have a really highly critical voice going on, and really knocks our self-confidence. So we're kind of often exploring narratives and working with cognitive distortions, you know, those sort of black and white, all or nothing thinking. You know, I'm a failure, it's no good, it's never going to be enough. And I think a lot of the work we do is helping people to get out of their heads and be in their bodies. We need to be in our bodies. Sex is the ultimate interplay of our mind and body. And so many people struggle to be in their bodies, either, you know, because of pain or discomfort, or this kind of spectatoring and monitoring. But actually, you know, it's really hard to be paying attention to our responses if we're in our heads and not in our bodies. So helping people to be aware of their own sensation and arousal, so that they can kind of tune in to using things like mindfulness or exercises to practice touch is incredibly common part of the work that we do as sex therapists. And improving sexual functioning and sexual skills, and varying limited sexual scripts. So for a couple who come in who have, you know, not experienced any difficulties with sex for a very long time, but one of them may have had surgery or hysterectomy or post prostate surgery, and suddenly the way that they've been able to be sexual has changed. And so if they have no other way of exploring or enjoying sexual touch together, then it can feel like actually we've got to get back to something, and if we can't get back to that, then what? It's as if, you know, that's kind of the end of the road. So really helping people to kind of broaden their idea of what is possible, and explore and develop alternative ways of being sexually intimate together is really a core part of the work too. And that may often involve more general couple work in terms of dealing with communication difficulties or unresolved issues that are also impacting on intimacy.
So that just sort of leads to a question that we've had sitting there with regards to practical ways for couples to actually come together and re-establish their intimacy. So what sort of tips would you give there to couples that need to re-establish their sexual intimacy?
Yeah, so I think, lots. I think the primary thing very often is people not creating the space and opportunity because the busyness and so often there are so many other things going on in life, and this idea too that, you know, it will just sort of happen spontaneously. And Stella Resnick, sex therapist, sort of talks about what she calls deadly marital sex is the last weary act of a long, tiring day. And so, you know, of course it's going to be hard to transition from our busy lives into being sexual and expecting our bodies to just kind of shift from, you know, doing our day and suddenly being intimate. So, you know, one of the ways is actually about the importance of prioritizing time and space for intimacy. And I think also being able to kind of think about flexibility, you know, so what within that, I may not be wanting to kind of have full sex, but what does each of you feel open and available to be doing?
Thank you.
So that's one of the things, creating the priority in the space. Marty Klein, the sex therapist who really talks about anxiety and this kind of pressure to be normal. So many times get asked questions of, is this normal or isn't this normal? Or how often should we be doing this or not doing that? And he says our yearning to be sexually normal combined with our anxiety that we're not creates often unrealistic expectations, focus on performance rather than closeness and pleasure, sense of emotional isolation and failure, and often an inability to be open with our partners. And so I kind of sum up really what I see sex therapy being is that good enough sex at every stage of our life is about learning how to relax, enjoy sex with the body you have, the partner you have, and the situation you're in. And so just wanted to then talk, just finishing up really, just talk a little bit about the kind of combined treatments. So going back to erectile difficulties as an example of that. So obviously PDE5 inhibitors, the first port of call very often for treating erectile difficulties. And I think the advances in sexual medicine have made a huge impact really on treatment for sexual difficulties. And there's been a sort of plethora of research that I guess really does support the efficacy of those for people where there is an underlying reason that, you know, it's going to be effective. And the efficacy rates are kind of around 60 to 70%, but also showing things like, you know, somewhere from a quarter to a third of men might experience an erection good enough, whatever that means, for intercourse on a placebo. So again, a huge sort of psychological aspect. But I think what's really important is that there are equal rates of discontinuation as there are for efficacy. So, you know, up to 2/3 of people stopping treatment after a few months. And I think, you know, these are some of the reasons which again can be really helpful in terms of your information as a prescriber and being able to advise patients. So sometimes it's to do with the kind of dosage not being effective, or the timing, you know, that often not being aware of the time that it might take, or still needing stimulation rather than expecting. So this is about expectations of how the medication would work. And I think a lot of the reasons that men might discontinue is because of this sense that it's not spontaneous and it has to be this sort of planned event. I often say, well, you know, spontaneity is a kind of myth, because if you think back the beginning of your relationship, you know, when you feel like it was spontaneous, actually there was an awful lot of planning going into dating and preening, and, you know, so how spontaneous was it? And unrealistic expectations. So I think, you know, the more that we can advise of what to expect, how the medication will work, what it will achieve and not achieve, I think the more that can prevent against disappointment and discontinuing use. And the other reasons obviously are things where actually there's no organic basis and the psychological difficulties remain. So if we think of all those psychological factors or relational factors, a pill isn't necessarily going to address those. But what it might do is help to kind of give a man a confidence or have a positive experience, which can at least halt or maybe reverse some of that downward spiral of failure and anxiety.
that probably answers part of the question that's come through with regards to, in general practice, we often have younger men coming in to ask for things like Viagra.
Yeah.
And the question was really based around, in your experience, would you consider sexual dysfunction and those sorts of requests being more of a psychological component rather than physical? Some in their 30s.
Yes, I guess potentially if we think about the physical risk factors for erectile difficulties, of course, if someone's got an underlying health condition, but sort of age or other medical conditions aside, but I think it isn't uncommon that younger men may be presenting with erectile difficulties because of things like anxiety, or increasingly seeing younger people with delayed ejaculation, and that might be to do with either some compulsive sexuality or compulsive porn use, and really finding it difficult to kind of translate their sexual arousal and sexual experience to partnered sex, and that's very different from masturbation. So I think, again, it's about exploring the potential causes. There may be medical reasons and it may be helpful, but there may also be a lot of other psychological, which may suggest that another treatment option could be beneficial.
Thank you.
Yeah, and often discontinuation of medication has been found because of kind of partners and relationship factors. So, actually reintroducing or becoming intimate again just because I now can, actually, that may require a whole lot of adjustment and rebuilding of intimacy in the way you just mentioned, Grace. So, those factors again need to be addressed. So I think, for this reason, I've talked already about the sort of psychological aspects, but for this reason, the idea of combined therapy it's being really helpful. Unfortunately, there's some research trials coming through now showing, so this is just one, but really showing that there was a fairly equal effectiveness in outcome of a group who just had Viagra and those who had Viagra and sex therapy. But for the group who had the sex therapy as well, there was much longer term benefits in terms of maintaining the treatment gains, learning kind of different ways of relating, addressing the relationship and intimacy issues, and addressing the kind of anxiety and psychological components. So I guess in a bit like we really understand now as kind of best practice with things like depression, that combining medication and therapy has the best longer term outcome, because you're really addressing the underlying causes or learning to make changes which are sustained once medication is stopped.
Right.
So this, going back to Luke, that's exactly in this case study, had a successful trial with Viagra and improved erectile functioning and confidence, but also needed to kind of be referred, because it had been going on 6 years, and so referral for sex therapy, which could really help them to, as a couple, learn to be intimate again and focus on learning touch. Sex have become very kind of intercourse focused, I guess, which is often very common in that, mustn't kind of lose my erection, and so actually that may lead to changes in sexual pleasure or experience for a partner. And the sex therapy here really kind of addressed that idea of spontaneity and how to incorporate planned sex, or needing to incorporate the medication into planning sex. And I often talk about that idea of sort of prioritizing and honoring time. There can be positive anticipation and simmering if you plan sex, as opposed to kind of feel like it will happen spontaneously. And the sex therapy and couple work in this case also kind of improve the communication and the ability for the couple to talk to each other about sex. So I just wanted to kind of finish it up with thinking a little bit about pain as well, because I think sexual pain difficulties have really been reconceptualized now. So this is the DSM diagnosis. Has really now been conceptualized as chronic pain conditions. So really thinking about why is sexual pain as a sexual dysfunction. We don't categorize other pain disorders according to the area of the body that they affect. And so helping to think about treatment of sexual pain difficulties as a chronic pain condition and requiring a multidisciplinary approach is really the kind of best practice now. So obviously sexual pain is multifactorial. All of the things we've talked about in terms of biological and cognitive factors, emotional, relational factors, and any of those things might be the cause or the maintaining of sexual pain. So we need to kind of have a very dynamic diagnosis. And it's multi-systemic, so sexual functioning involves all of those aspects of our bodily function, as well as the immunological systems and integrity of the vaginal ecosystem. So, the ideas that now thinking about that pain is, rarely psychological or psychosomatic, that even in the absence of sort of kind of acute cause of the pain, that pain is now more like a chronic pain condition where there's been sensitivity and centralization of a kind of pain, and so that even if there was an organic reason, that actually a whole pain cycle has now been set up which needs to be addressed. And authors like Rosemary Basson really talk about that there might be kind of micro trauma, and so in vulvodynia that may have long healed, but actually if the pain has become chronic, then it will be experienced as a chronic pain condition where all of the psychological elements will be at play. So things like negative anticipation of pain and fear and avoidance or interpretation of the meaning of pain. So the idea, I guess, that our overall experience of sexual functioning is greater than any one of those, and the experience of pain is over and above the simple original kind of acute injury or problem. So I think thinking about sexual pain is really helpful to think about it as a vicious cycle. So whatever the original cause was that has set up the pain experience, then there will be stress associated with that. There will be often feelings of kind of shame, inadequacy, loss of confidence. There might be relationship factors. So stress, as we know, will compound the experience of pain. Anticipation of pain means that we're likely to be tense, not relaxed. Then there isn't physiological arousal, and so we may not be as well kind of lubricated or experiencing kind of normal sexual arousal, which will add to the pain. We know that both of those things, the psychological and physical conditions, lead to changes in pelvic floor functioning. So there's actually muscular changes or vaginismus, the vaginal muscles. So those will then be more pain producing, and very often people continuing to try and experience intercourse when there's pain, and so that continual attempts just maintaining that whole sexual pain cycle. And so the approaches are really about intervening in all of those areas in terms of the organic difficulties, the pelvic floor changes that have happened, and the psychological and relational aspects of treating the pain condition. So I think I've said most of this. Yep. So the main thing I guess I wanted to say around that is that in terms of treating pain, I think it's really important. Many women that I've worked with will report quite a long history of trying to get their pain condition kind of recognised and understood, particularly if it's been going on a really long time. They may have gone around the houses and seen lots of people and can end up kind of feeling that it's all in their head, particularly if the original cause of the difficulty is kind of long cleared up. So it's really important, I guess, that there's really thorough medical investigation of any cause or coexisting health condition, whether that's through sexual health or gynecology. The referral for pelvic floor physiotherapy, I work always when I'm working with women with sexual pain conditions, is to make a referral through to pelvic floor physiotherapists to really address the pelvic floor changes through the use of stretching, relaxation, breathing, biofeedback, the use of dilators, because I guess if you're just trying to attend to only one of those aspects, and unless you're dealing with the kind of physical changes that have happened, you're going to continue to experience pain, and really wanting women to not continue to experience sex if it's painful.
Sure. Just a question coming through with regards to self-care and resources that perhaps a patient could access for this particular type of problem. Do you have any suggestions?
Yes, so one of the resources that's on the very last slide is it's called a sexualityresources.com. That's a fantastic website which is run by a medical practitioner and sex therapist, and it covers a whole range of presenting issues, but there are really helpful fact sheets on there for clients on everything from kind of recovery post-prostate to masturbation to menopause, pain disorders. So that's a really, really good website for pointing people to in terms of self-help resources.
Great.
There's also vaginismus.com, which is a kind of online self-help program that's very much based, written for women as a self-help program. But I would always encourage women to be, having these assessments both with medical and pelvic floor and psychological treatment. But there are self-help kind of guided programs as well online.
There's also a question that's come through with regards to sex abuse and, in your opinion, how much of a role does it often play in these sorts of conditions?
Potentially, yes. I guess that's, if we think about the psychological components, so early, I would say, sexual abuse certainly, but other forms of trauma and abuse can also have an impact on sexuality and intimacy, and can often kind of get overlooked, the effects of physical trauma and abuse. So I think it's always really important to kind of screen or ask around that, because it may be that that's really needs to be addressed alongside or even before. So, I do a lot of work around sexuality in that context of trauma, and it's often really important that the general work about resolving the impact of trauma is done first before addressing kind of sexuality.
Okay, and your discussion has brought up quite a lot of questions with regards to sex therapy and funded sex therapy. Is there any funded sex therapy that you're aware of?
Well, the sex therapy is a private company, I guess, so that's self-paying. There is very limited, as I understand now, through the sexual health clinics. I think the sort of psychosexual therapy has ceased. I'm not sure if that's certainly in Auckland, but around the country. So there's very limited options. ACC can cover sexual dysfunction treatment, but of course it would need to be subject to it being a covered injury and the processes for that. But under sensitive claims or physical or treatment injury, then potentially that could be funded.
That's helpful.
Yeah.
Thank you.
So just very briefly before we finish, there's Lucy. So just an example of a 31-year-old in a marriage for 5 years, had a 3-year history of vulvodynia that was recently diagnosed, but had been experiencing a lot of pain and difficulties for a while, and had really ceased kind of sexual intimacy, continued to try and be intimate, but having a lot of pain, and eventually stopped being sexual, was avoiding sex, kind of felt like really hopeless, really lost confidence, really felt helpless, I guess, and often hear quite a lot of despair, decreased desire and interest in sex. And so she was referred for gynecology and follow-up appointments and pelvic floor physio. But the sex therapy was really about kind of working on these aspects, the validation and the acknowledgement that this pain is real. A chronic pain condition is real, and it's not kind of all in your head. Certainly psychological factors compound pain and maintain pain, but it's not the only cause. So being able to educate about pain and really encouraging people to stop things that are pain producing, that's really often the role of sex therapy. And so starting with rebuilding intimacy, rebuilding touch, and exploring sexual touch that's not pain producing, so that you're not continuing to reinforce that cycle both physically and psychologically, and maintain things like altered pelvic floor functioning. So working to kind of improve sexual self-esteem, I call it, kind of confidence, and improve the couple relationship. So with Lucy being able to really help them to rebuild a new and different experience of intimacy, and incorporate pain whilst that was being treated, physically and with pelvic floor physio. So I guess that brings me to the kind of main take-home points, which I think is, firstly, it's okay to ask. And people will tell you if they don't want to talk about it, and people will mostly be grateful for being asked. And that, the messaging really just thinking that we've got to think in a broad biopsychosocial framework. So even if we're just doing screening questions, if we've got that in mind, that just a few brief screening questions that cover those different aspects. We don't need to, and nor would expect people, depending on your role, to be kind of go into undertaking a full sort of psychological therapy assessment, but just thinking about that framework and thinking about what works for whom. So I guess there's no one size that fits all, and it also depends on the person's goals and motivation or affordability. Those things, about tailoring to the individual person in front of you, and thinking about kind of virtual multidisciplinary treatment. So being able to refer on to specialists as well as yourselves, if that's appropriate, as a kind of virtual team. So that's brings me to the end.
Fantastic.
You.
We do have some questions.
Yeah.
First, I'll just highlight those references and resources there. We'll be putting those up on our website later. Now, questions, we've generated a few, and we've got a bit of time here, so we'll go through some of them.
Yeah.
Let me just scroll up a little bit. Okay. So I think the first question we're just going to talk about is a little commentary on sexual fluidity in women, and also how things change when we approach menopause. Any commentary on that?
There's sort of two separate questions in one, I think.
Yes, you're right.
Sexual fluidity in women, I'm not sure really what that question is asking, but I guess sexual fluidity of thinking, I said earlier, beyond this sort of very binary, we're either kind of gay or we're straight or we're male or we're female, and, to thinking about actually, who we're attracted to is very different from who we have sex with, and how we identify ourselves is also different. So many men who would have sex with men but would identify as heterosexual. So I think the question of fluidity is just that, of thinking about sexuality as fluid and not necessarily kind of fitting into any particular categories.
Okay.
And so keeping those kind of broad frameworks, I guess, in mind. And also thinking about languages and languaging and assumption, I guess, asking someone about a partner rather than husband or wife.
Okay.
Yeah. Okay. And in terms of menopause, again, I think, that idea that there are changes that happen with menopause physiologically in terms of, vaginal tissues and lubrication. So there are physiological changes that happen. There may be hormonal changes that impact on desire. But again, a lot of the research on menopause shows that it's really hard to differentiate what's due to those physiological changes and what's due to the kind of contextual things, the psychological transition to menopause, or obviously with age and life stage, other things that might be going on around menopause. So if there are sexual difficulties, how much is it due to the physiological effects of menopause per se? How much is it due to those kind of broader psychosocial elements that go with menopause as well?
Okay. Speaking of ages and change, moving right to the other end of the spectrum, we've got a question with regards to, someone said, while working with youth, I've been asked if it's common for girls not to be able to have an orgasm. Can you please give some advice with regards to
younger people?
Yeah, that's right.
That.
Yeah.
I think what I would say about that too is focusing on orgasm per se might set up anxiety, might set up that kind of performance. That's the goal I've got to get to. What I be wanting to think about is those stages before, is there willingness, is there arousal? So if we can work on looking at things that might be heightening arousal or things that might inhibit arousal, then orgasm may be much more likely to happen kind of as a byproduct of that, rather than very often people kind of striving to reach orgasm. So I think it's about exploration and exploring bodies and understanding what your own arousal patterns are.
Okay. There's a question about porn habit. So people that present with issues around porn, what treatment would you suggest around this?
Good question. That's a whole nother topic.
I know. I was hesitated to ask, but it was there.
And I think like with any sexual practice, thinking about, is this harmful or not? Is this kind of what is the place of porn? So, is it something which is causing difficulties either for that person or for the partner or the relationship? Is it out of control in some way? Is it in terms of the requirements to kind of watch porn or only get aroused to porn, or the amount of time that someone's spending porn?
Sure.
So I think it's first of all kind of deciding how problematic it is, and then in terms of, well, what do we do about it? Then I think it's about kind of creating behaviour change. What are the person's kind of goals around that to reduce porn? Sometimes it's about needing to stop porn use. Very often porn use may be part of emotion regulation or self-soothing or stress management. So if it has a function around that, then if we're taking porn away in the same way as any other kind of substance that might be having a function, helping people to develop other ways of managing stress or distress, might be part of the what's required.
Might have to save that talk for a whole other session. All right. Well, that's probably all we've got time for. Just to let you know, if anyone wanted more information about this particular topic, Alyson's actually holding a 2-day workshop. I think it's on the 9th to the 10th of May.
Yeah.
Further details are on our website. That was really, really useful. Thank you so much for coming on board and talking to us about these things, particularly opening up the question for it to be okay to ask about sexual dysfunction. I think a lot of us find that really difficult, and having an assessment framework to actually base we should be looking and how we actually approach things. That's fantastic. Thank you.
You're welcome. Yeah. And if anyone's got any queries or questions, feel free. I think my email will be somewhere on advertising, and all my colleagues at Sex Therapy New Zealand. So people can self-refer to Sex Therapy New Zealand. The website link is there. Please feel free to get in touch.
Great. And for those of you who didn't quite catch the resources, don't worry. A copy of this video will be available shortly with any associated links. So thanks again, everyone, for joining us, and thank you, Allyson.
Thank you.
And good night.